Thank you very much. Thank you very much for inviting me here. It's been a fantastic meeting so far. I've been tasked with to talk about fitness and predictive scoring systems for patient selection in aortic surgery. And in fact, I'm going to just predominantly focus on I'm going to solely focus on abdominal aortic aneurysms. And before I get into assessment of fitness and scoring systems, the current guidelines would suggest that in men at a size of 5.5 centimetres maximum diameter of your abdominal aorta or above, you should consider intervention. And in women, if they are fit, i.e. have an acceptable surgical risk, you should consider that at 5 centimetres or above. But I think there's been some, in the context of fitness and scoring systems, one has to actually work out, well, what's the risk of an aneurysm rupture? And I think some of the data has changed a little bit over the last few years. This is data from Jonathan Earnshaw, who led our national aneurysm screening program in the UK, that would suggest that if your aneurysm is between 5 and 5.4 centimetres, which is the upper size that patients would have within the screening program, that your rupture rate was actually pretty low, less than 0.4%. And in fact, what you tend to die of is your cardiovascular event rather than your aneurysm. Chris Twine from initially in Wales, now in Bristol, did a meta-analysis of untreated aneurysm patients, and again suggested that the rupture risk per year was lower than that historically we have quoted. And more recently, there's this large study that's come out of the United States that will confirm the findings of Chris's study, suggesting that in men, an aneurysm between 5 and 6 centimetres has a rupture risk of about 2.2%, 6 to 7, 6, and then once you get above 7, that's where the rupture risks really start to get quite significant. So it's in that context, I think, that one has to determine how a patient is, how fit the patient is, and then as part of this, you're trying to determine that risk-benefit assessment in what is a prophylactic procedure. So you're trying to balance up the rupture risk with the intervention risk, and the intervention risk is partly anatomical, but significantly operative fitness. The question of, well, can we reduce risk is really for a different talk. I present this is data from the National Vascular Registry in the UK. This is data that we present every year. This is from 2021, I think. But it shows for open repair, our in-hospital mortality rate in the UK is currently about 3.3%. For EVAR is 0.5%. So again, that gives us a feel about what your operative risk should be and the risk that you're willing to sort of take on, really. So what should we do to assess fitness? History, examination. I think if patients have got active cardiovascular disease, they should be seen by our cardiologist. The standard bloods, and I would suggest an echocardiogram and some pulmonary function tests, and then some form of functional assessment. Now, there's this concept of metabolic equivalent thresholds, or METs, and this is sort of split into poor, moderate, good, or excellent, and examples of activity are seen in this table. And specifically for moderate, you need to be able to climb 2 flights of stairs. And in the institution I used to work in, echocardiogram, pulmonary function tests, and the anaesthetist walking a patient up 2 flights of stairs would tend to be the functional assessment that we would do. And METs has been shown to actually predict reasonable cardiac prognosis in the context of surgery. Obviously, as time goes on, we have more and more ways of assessing objectively fitness. This is CPET, or CPEX. It gives you an objective measure of functional reserve and allows you to determine some objective parameters. Essentially, the main one is this anaerobic threshold, which people use to try and determine risk and benefit from surgery. And the question really with CPEX is, are we looking at our ability to turn down patients using CPEX, or using it as a triage towards an identification of need of more intensive care facilities? data's out there with regard to 𝗔𝗋𝗋s. The European guidelines would suggest that the data doesn't suggest routine use. And this recent this meta-analysis done by the St George's Group about 6 years ago would confirm that. There were about 6 or 7 papers that they looked at, but the data quality was pretty poor throughout all these papers, and their conclusion was paucity of robust data precludes the routine use of 𝗔𝗋𝗋s. Now in the UK recently, I'm sure you've all heard about 𝗙ice and the 𝗙ice recommendations on abdominal aortic aneurysms in general. Apart from whether we should do EVAR or open, they've actually been quite useful in looking at quite a lot of the evidence. And the evidence with regard to 𝗔𝗋𝗋s is that you should consider it when assessing people for elective repair, as it will assist in shared decision making. But if you delve deeper down into what they say, they also confirm that the evidence is limited, but that the committee felt that as 𝗔𝗋𝗋 was quite widely used in the UK, it may have a useful role in shared decision making with the patients. Moving on, I was asked to talk about predictive scoring system. There's lots of them out there which would suggest that they don't work very well. And that again was looked at by 𝗙ice. They looked at 11 scoring systems that are focused on abdominal aortic aneurysm prediction. The studies were mainly retrospective. A number of them had large numbers that were taken from national or international vascular databases. But to determine whether scoring systems work well, you need to look at area under the curve. And in fact, the area under the curve for all of these scoring systems was at best moderate, at worst poor, with an AUC ranging from 0.65 to 0.75. And when you compare that to some of the cardiovascular disease scoring systems, they have significantly better area under the curve. So 𝗙ice felt that these tools had insufficient discriminatory power and could have a potentially harmful effect on patient care, because you may put a patient who would benefit from operation into a non-operative category or vice versa. I think it would be remiss of me not to mention frailty. Populations are ageing. Certainly in the UK, our population is significantly ageing, and with that it provides us with lots of challenges out with your usual cardiorespiratory assessments. Frailty is multidimensional, and essentially what it means is that patients don't have that physiological reserve to fall back on at times of stress. This is some data that we did when I was in Cambridge in the UK. We looked at about 500 patients who, across vascular surgery, the spectrums of vascular surgery, and tried to assess their frailty, and essentially showed that the more frail you are, the worse your long-term mortality. So the more frail, the worse you do. And this has been borne out in studies that have both looked at EVAR. Here, a Dutch group that showed that there was strong correlation between frailty and poor outcomes in EVAR. And also, this is a paper from the Stoke unit in the UK that looked at their National Vascular Registry data over about 6 years. And again, they found that the most frail patients in open abdominal aortic aneurysm repair did poorly. And so increasingly, we're needing to use or asking to use our geriatricians alongside our anaesthetists in the assessment of our aneurysm cohorts. There are some factors within frailty that you can modify. There are some factors within frailty that you can't. But I think increasingly that's becoming a real significant part of our preoperative workup for aneurysm patients. So where does this leave us? Well, some personal thoughts from me. I don't think there's one test that's going to give you the answer. I think you can use 𝗔𝗋𝗋 as part of your armamentarium, but don't rely on it solely for turn down or opt-in for aneurysm surgery. There's a series of routine go-to tests from the point of view of basic assessments, and no doubt functional assessment is important, but I think you can walk up and down, the patient can walk a patient up and down a couple of flights of stairs to get a reasonable assessment of their function. Consider frailty, work within an MDT, but ultimately, as we've talked about throughout this meeting this morning, it's about a per patient, it's discussion with the per patient. It's difficult to accurately determine a per patient risk, but the decision to intervene must be patient-centred. Thank you.